Hi, my name is Phil Brewer, and good afternoon, and thank you all for coming. I practiced emergency medicine for 35 years, and I work with Physicians for National Health Program, which has organized this press conference. In association with the Connecticut Citizens Action Group, the Center for Medicare Advocacy, and Medicare for All Connecticut. Through intense but deceptive advertising, Medicare Advantage has steadily increased its market share, which is now more than 50% of the Medicare-eligible population. Through pre-authorization denials, limited networks, ghost networks, upcoding, and fraudulent billing, Medicare Advantage has steadily increased its income, which nearly tripled between 2011 and 2021 from $124 billion to $361 billion, and is projected to increase to almost $1 trillion by 2031 if nothing changes. The annual Medicare open enrollment period will begin in 2 weeks, and we want the public to be aware of the many issues with Medicare Advantage when they make crucial decisions about their health care coverage. Sadly, abusive practices of Medicare Advantage have serious consequences on the lives and health of many of its recipients. Our speakers today will be Senator Saud Anwar, who is also a practicing critical care physician, Senator Richard Blumenthal, and Gloria Bent, the widow of Mr. Gary Bent, who spent the last 2 years of his life fighting not only 2 cancers, but his Medicare Advantage plan. We will also have Susan Johnson, Representative Susan Johnson, and Judith Stein of the Center for Medicare Advocacy, who will address impending problems that will adversely impact Medicare Advantage customers. Public financing of health care is the most efficient and equitable model. Medicare pays out $98 in health care for every $100 it collects. Medicare Advantage pays out only $83 on average and keeps the rest. Our current system allows the limitless greed of for-profit health insurance companies to distort our care by misleading seniors and denying care, giving them billions for stock buybacks, executive pay, and profits for already rich shareholders. After our speakers, we will take questions, and we have information that we can hand out for those who have registered for Medicare Advantage and want to get out and go back to traditional Medicare. I'd like to thank Long-Term Care Ombudsman Mary Painter and Senator Anwar for hosting this event. And I believe, yeah. So now I pass it to Senator Blumenthal.
Thank you. Thanks, Dr. Brewer. Thank you to all of my colleagues who are here today. I particularly want to thank Dr. Anwar, who is such a tireless crusader for better health care, and his colleague in the legislature, Susan Johnson, who stands up every day for her constituents. I'm also, again, honored to be with Gloria Bent, whose husband, Gary, as you've heard, spent the latter part of his life fighting for decent health care. And Gloria came to Washington, D.C. and gave the benefit of her experience to the subcommittee that I chair, the Permanent Subcommittee on Investigations, which is conducting an investigation of Medicare Advantage. We will have a report to be issued very shortly in the next few weeks, I expect. And then Judith Stein, who has been a champion for, I'm tempted to say decades, it is decades. She is tireless and relentless as a champion for better Medicare in general and better health care. The Permanent Subcommittee on Investigations will be issuing a report shortly. I'm not going to preview it here, but anybody following our hearings and public comments so far knows that our findings will be very dramatic and powerful, because what we have found is essentially there is no advantage for patients in Medicare Advantage all too often. For all too many of the people of Connecticut and the country, there's no advantage to Medicare Advantage. There's a distinct disadvantage. too often. And for taxpayers, there is definitely a waste of money that borders on scandal. And the reason is quite simply that the insurance companies are profiteering. They are taking advantage of excuses to deny or delay coverage. And the victims of those practices are patients and their families like Gary Bent. What happens all too often, either before surgery or afterward, during some kind of care, coverage is denied or delayed. For example, somebody coming out of surgery who physicians believe should go into rehabilitation is denied that kind of care. And what a lot of people don't realize is that the tactics that the insurance companies use involve artificial intelligence, the black box algorithms that they use to say, in effect, prior authorization will be denied. And frankly, the victims of these tactics are often the physicians who believe that their patients need and deserve certain kinds of care. And their professional approach is, in effect, disrespected. Now, these practices are not new. Medicare Advantage has been a profit center for insurance companies for many years. I've asked CMS to do more to stop the overpayments and the denial or delay of care. But the insurance companies continue to say that a particular kind of treatment is out of network, that a particular physician or provider is outside the limits of the Medicare Advantage plan, or that the algorithm shows that a particular kind of care is not appropriate. And the gross margins for Medicare Advantage are now roughly twice what they are for other individual or market care. The amount of government spending this year will be about $462 billion for Medicare Advantage. Let me repeat. Your money, taxpayer money, will be used to the tune of $462 billion for Medicare Advantage. Something's wrong with this picture. Patients, taxpayers, physicians, all deserve better. If it's going to be Medicare Advantage, it ought to be a real advantage, not the disadvantage it is right now. And so I think the time for reform has come, and that's why we're here today, to demand reform, a crackdown on abuses involved in Medicare Advantage, including potentially going into this open enrollment period, deceptive or misleading practices. I wrote last January calling for an end to deceptive and misleading practices by the insurance company, particularly United Healthcare in that instance. These deceptive or misleading practices may be now rampant at a time of open enrollment. People should be wary and aware of those kinds of misleading ads or pitches, promotions, as we go into open enrollment. So don't just jump into Medicare Advantage because the insurance company tells you it's better for you. In fact, it may be hazardous to your health. Thank you.
Now, Senator Panel.
Jacob Shepard Sadel.
Thank you so much. Thank you, Senator Blumenthal, for your leadership. Thank you for all my colleagues and friends who are here, because this is one of the most important topics that we should be having a frank conversation about. As people are going to be asked to become enrollees for Medicare Advantage plans, it's important to know that our seniors, our elderly in the community, their families, the healthcare providers, and the healthcare systems, their viability is all dependent on this choice. You just heard about some of the areas that Senator Blumenthal has touched on. I want to share the same thing and also add a few percentages and numbers to it. And this data, if you really listen to these numbers, this is not a sustainable situation for us, any society. 80% of all Medicare Advantage enrollees pay higher out-of-pocket costs. African Americans and Native Americans who are Medicare Advantage enrollees have worse outcomes. If you look at diabetes, for example, and there are 41 key measures, they are below average in 18 of the 41 measures. Minority groups, the blacks, the Hispanics, have a higher likelihood of being part of a lower rated plan that limits their access to care and reduced access to specialty care. This is our tax dollars that are being used, and they are being used by insurance industry to be able to reduce access to our community members. Then 98% of the hospitals report negative impact due to prior authorization practices. The administrative barriers have been increasing exponentially, essentially every year. And the hospital care that was about 13% Medicare Advantage way back in 2015 is now 23% in 2022. The rural hospitals and all hospitals are dependent on timely payment for their survival. And because of the administrative burdens and the processes, that has resulted in the viability of the healthcare systems. And in Connecticut, it's very relevant because we are talking about potentially 5 hospitals at the brink of not being able to survive. Amongst a number of different things, the Medicare Advantage plans and the non-payment or delayed payment is part of the problem. Taxpayers are being overcharged. In 2013, there was data that was $1,000 per patient was being overcharged, and just in the last 3 years, our government has been overcharged by the insurance companies by $30 billion. And now you're looking at the dollar amount, but behind these dollar amounts are lives lost, medications denied, timely tests denied. The country which has been at the peak of scientific discovery, who has treatments for almost all illnesses, cannot provide care to their own citizens because of the malignant greed that the industry has, which has just as a cancer eaten up your savings, the government opportunity to be able to provide care to our citizens. 97% of our physicians feel that prior authorization caused delays in treatment and has increased the burden of cost of care. In 2022 alone, 3.4 million prior authorizations were denied. 3.4 million were denied. This is all Medicare Advantage, and that is 7.4% of all requests, medications, tests, and surgeries. 83% of all of the appeals were successful. That tells you how many of those appeals and initial denials were wrong. And this is at the cost of significant burden in the healthcare systems to have people fight on the phones in the archaic manner to wait and listen to music for hours to be able to get their medications for their patients approved. A few years ago, I tell this story. I'm a pulmonary doc physician. Many years ago, one of my staff person resigned. And she had been working with us for 16 years or so, and she said, now for the most basic rescue inhaler for asthma, the most basic rescue inhaler for asthma, she had to wait and listen to music for 15 minutes to get it approved for patients. She said, I wanted to interact with humans, I wanted to take care of them, but now waiting and listening to this music all day for the most basic things, I can't sleep at night because I feel how there is a moral injury to the people who are in the process of trying to save lives, save quality of life of our citizens. And you've heard about this insurance company's algorithm, PXDX, from an insurance company based out of here in Connecticut. Their denial rate was a denial every 1.2 seconds. They're denying care every 1.2 seconds. and every 1.2 seconds, one individual is not getting the test that they need, the medicine that they need, the surgery that they need, and that's based on artificial intelligence alone. They claim it's not artificial intelligence. They will claim that it's actually healthcare providers who are in the picture who are making that decision. This is what's going on right now. 74% of the nurses have reported that they have increased in their administrative tasks. And if you look at, in order to deal with the fight of prior authorization and working with the administrative burdens associated with Medicare Advantage, the cost to the healthcare system just to do that is in the tune of $40 billion. And then people say, why is the cost of healthcare going up? The reason healthcare cost is going up is that every office, medical office, every hospital has a fleet of people trying to get prior authorizations to be able to provide care to their patients. And the delay and the lack of treatment is another financial benefit to the insurance industry, which is completely involved in this effort. So this is not a sustainable model for any society, let alone one of the most progressive societies in the history, to have to deal with this. So like Senator Blumenthal has said, time has come for reform to fix this. And I stand united with everyone over here to make sure that we get the word out that this is not a sustainable model and talk about how we need to fix this as well. Thank you so much.
Thank you so much. And what a pleasure it is to be here today to be able to talk about the Medicare, and as I've heard everyone say, the Medicare Disadvantage Program, because it really is creating disadvantages for people all over the state of Connecticut and in my district. Many of you know perhaps that I worked with Judith Stein at the Center for Medicare Advocacy, and before that, the legal assistance to Medicare patients. So I have a background in the area, and when somebody calls me about a problem with Medicare, Medicaid, those kinds of plans, I can understand exactly where the problem is because some of those regulations are etched indelibly in my brain. So I know that one of the first things that I'll say is that we need to understand, first of all, that Medicare Advantage is a health maintenance organization, Medicare Part C. The providers, they get a basic rate, the insurance company gets a basic rate for how many people they have, and then they have an incentive, really, under an HMO to deny coverage because the less coverage they provide, the more they get to keep. And as you heard today, the medical loss ratio for the Advantage plans is about 83%, and for regular Medicare fee-for-service is about 97%. So those are some of the things, but I want to focus really on my constituents because my constituents have been treated very poorly. And I'll start off with the idea that the Medicare Advantage plan must provide the exact same thing that the Medicare fee-for-service A and B provides. And as a Medicare Part C, they have to do the same thing. So the first example is I have a call from somebody who is in a skilled nursing facility, met all the requirements for hospitalization, met all the requirements for needing skilled daily care, and was denied because the Advantage plan told the social worker that they were out of time when they had only been in there for 40 days. You get 100 days of coverage under Medicare. So what happened to the other 60 days? And so that was one example, and I referred them right over to my former boss, Judith Stein, and said, hey, help this person out and get this thing appealed. The second way that they deal with the problem is something that adds a little more complexity to it. The Medicare Advantage plans are supposed to provide the exact same thing, as I said before, that regular Medicare provides. Yet they have these networks, and they negotiate with the providers of certain networks. And so here's the second one. I had a constituent who had a hip replacement. And the doctor said, well, you can have home care services. And so the person went home and was supposed to, it's homebound. One of the requirements for getting home care services is you're going to have difficulty leaving the home and needed some kind of assistance leaving the home. In this case, this person had other types of mobility problems, not just from the hip replacement, but had chronic mobility issues. So what happened is they go to get the physical therapy for in-home care. Guess what? The network didn't provide for in-home care, for home care services. That particular Medicare Advantage plan didn't have any providers that were anywhere near this person's home. That person had to take the risk of leaving with assistance to go to an outpatient clinic when they really needed to be in the home for the first few weeks after surgery. This could have created a problem where they would have had more injuries because they weren't being covered the way they should have. And how do you deal with an out-of-network problem when there's no network provider to provide the care in that circumstance? So they didn't have the money to deal with this. This is a horrible situation. Finally, we'll add a few more complexities to this. Now, here in the state of Connecticut, we have a wonderful Medicare Savings Program. Medicare Savings Program is supposed to cover all the deductibles, insurance premiums, depending on your income, and co-insurance payments. What happens is you really don't need to be in an Advantage plan if you have Medicare savings. Nevertheless, we have brokers that don't understand that, sell this to people who are on the Medicare Savings Program that have free coverage in terms of their deductibles, in terms of their co-insurance amounts, in terms of their premiums. And they're still going to pay a fee to the Advantage plans, be excluded from networks because they're not providing the adequacy in terms of network access for the provision of care. And here we are again with a problem that's very complicated and that we need to really take a look at, because if they don't have the network, why would somebody limit their access to care by putting themselves in a so-called Advantage plan when they really have access to regular fee-for-service with no network requirements in the regular Medicare Savings Program? These are things that they're collecting money on that shouldn't be sold, and these are things that limit people's access, cause them more serious illness, cause them more difficulty. And the plans are probably confusing enough without adding these levels of difficulty, without adding the problems of not having an adequate network. This shouldn't be, and I just can't thank everybody enough for being here today and listening to this, because these are problems that must be solved, and we need to really take a look, as Senator Blumenthal said, at how this is working or not working. Thank you so much.
Now, Gloria Bent, who will talk about her personal story.
Thank you. Because this is a kind of a raw story for me, I'm probably going to read much of it. I'm here to tell you about my late husband Gary and our experience of Medicare Advantage. Gary was a scientist, a teacher, an advocate. He was a firm advocate for issues of social justice. He was a loving father. He was my spouse and my best friend for over 56 years. He was also a retiree from the state of Connecticut, and in 2018 was moved by the state of Connecticut from traditional Medicare to a Medicare Advantage plan. In the spring of 2022, he experienced the return of a melanoma that we all thought was in remission. He underwent surgery to remove a bleeding lesion in his brain. Post-operatively, he had significant mobility and cognitive deficits. His brain no longer recognized that there was a left side to his body, so he couldn't stand, he couldn't walk. Simple tasks like telling time or reading a calendar or using a phone were things that he no longer remembered how to do. And he was frequently confused about where he was and why he was there. His neurosurgeon and the physical therapist seeing him at the Dempsey Hospital said that he was going to need intense rehabilitation services. There are 3 facilities in the state of Connecticut that provide rehabilitation services at that level. One of them had a bed for him and accepted him as a patient. This, however, required pre-authorization. and Medicare issued a denial, saying that he couldn't handle that level of treatment and he wasn't going to improve quickly enough. It boggles my mind that the physician and the physical therapist who are at his side every day say that he needs this care, and someone somewhere in the Medicare Advantage plan who's never even seen or met my husband says no. They did approve admission to a short-term rehabilitation and a skilled nursing center. But even that step in the reduction of level of care did not stop Medicare Advantage from issuing notices of termination of payment. Over the course of his 49 days in the facility, we experienced 3 attempts to end his care. We appealed all 3. We lost 2, or we won 2, and we lost the 3rd one, and he was discharged. Gary came home from the skilled nursing facility, which Medicare Advantage said he no longer needed, with a fever, a headache, and complaints of neck pain. He had been discharged with bacterial meningitis. He was home 11 hours and then immediately returned to the Dempsey Hospital, where he was in treatment for 3 weeks in critical condition. In that time, he lost all of the motor skills that he had worked so very hard in rehabilitation to reacquire. His hopes of becoming strong enough to return to the immunotherapy that had managed his melanoma were dashed. Upon his discharge from the Dempsey Hospital, we brought him home, and my daughters and I became his full-time care providers until he passed away March 3rd, 2023. After Gary's death, we learned that the denials for his care were computer-generated. Algorithms calculating the lowest common denominator of care based on the outcomes of hundreds of cases similar, however remotely similar, to my husband's case. No patient and family in this kind of medical crisis should have to fight artificial intelligence for the care that would have been provided to them under traditional Medicare. But that is exactly what is happening again and again all across the country. We are one family in an ocean of families who have been struggling under a barrage of denials, or are learning at the worst possible time in their lives that while they've been told that they can see any physician or service that accepts traditional Medicare, what they haven't been told is that in increasing numbers, physicians and those services that accept traditional Medicare are no longer accepting Medicare Advantage plans. I choose to believe that the dark side of Medicare Advantage plans is finally coming to light. If you are, here's my ask for today, if you are here or listening, a decision maker or a negotiator for retiree health benefits, please take a good look at the underside of these plans before you sign anyone else up. If you're a reporter, please tell the stories of people who have been traumatized by these plans. If you're a Medicare eligible senior entering this open enrollment period, please, oh please, be sure you understand what you just might not be getting when you need it most. Thank you.
And we'll end with Judith Stein from the Center for Medicare Advocacy.
Thank you, Mrs. Bent. It was our pleasure to try to help. And it's remarkable that the Bent family has taken this up as a personal advocacy mission to make the word, let the word go out. You must look before you leap, because Medicare Advantage will not provide the care that your family member or you need, as well as traditional Medicare would, when you absolutely need help. So when you're making choices, first let me say I'm Judith Stein. I'm the founder of the Center for Medicare Advocacy, and I'm an attorney, and I have in fact been doing this work for decades. And I often think that we've taken 5 steps back, that we're not moving forward in terms of getting care to people. The fact of life is that you will get sick, and you might get injured. And as we age and or have disabilities, we must face the reality of this. And what the program, the promise of Medicare was that we were going to provide basic quality health insurance for people as they age and live with significant disabilities, because you will get sick and you might get injured. So as Susan Johnson, my friend and former colleague, said, Medicare Advantage is required to provide under the law exactly as what traditional Medicare is required to provide. In fact, it's authorized to provide more. So for example, people are now being offered flex cards, gift cards by their Medicare Advantage plans. Or they may get a certain amount to go to the dentist, which should be in traditional Medicare but isn't. But when they get sick and or injured, the gift card is not worth anything to them. You can go to CVS and buy insoles for your shoes even, or a Pez, but it doesn't get you health care. Medicare Advantage, nonetheless, is currently the source of health insurance for the majority of Medicare beneficiaries. 54% of all beneficiaries across the country, and unfortunately it's now higher in Connecticut, 56%. My organization was contacted on behalf of a 95-year-old beneficiary 3 weeks ago, this summer, who fell and spent hours on the floor in her basement as she lives alone, until she was found the next day by Meals on Wheels, another wonderful program that not just provides food, but this kind of oversight to make sure people are well. She had to go to the hospital. She had been independent until that time. She was dehydrated and badly banged up. And from the hospital, she went to a skilled nursing facility for nursing therapy and recuperation. Unfortunately, this lady was a retired Connecticut employee. As a consequence, she is in a Medicare Advantage plan. She had no choice. Medicare Advantage denied her coverage after 11 days in the skilled nursing facility to a 94-year-old woman who is so strong and independent that she made it through the night and was ready to get on with what life she had ahead. But they told her that she couldn't improve, which, by the way, if you ever hear that, call the Center for Medicare Advocacy. It's not a legal standard. We appealed. It was finally granted. And fortunately, she was able to afford to stay for the days in the nursing home while the appeal ran. Last week, we got another such call from a gentleman whose 95-year-old father was denied after 10 days of care in the nursing home, though his therapists and nurses and doctors all said that he needed more care, and if he got it, he could return to independence where he was before he had also fallen. As Mrs. Bent said, the same thing happened to him.
Doctors who had never seen him, a consulting MD, told his Medicare Advantage plan that he could go home. And he had to because he couldn't afford to stay in the nursing home. And ended up declining and needing another hospitalization. This is not just inhumane, it's expensive. And unfortunately, Connecticut has most of its retirees in Medicare Advantage plans. Private Medicare Advantage is taking over the Medicare program at an astounding cost to people in Medicare, as you've heard, the Medicare program itself, and taxpayers. About 22% more than is paid for people in Medicare Advantage for each beneficiary than if they were in traditional Medicare. And what extra are they getting? A gift card, maybe a cleaning and the dentist. Significantly, older people and people with disabilities often actually have no choice. As I said, increasingly, public and private employers offer Medicare Advantage for their retirees. In fact, 20% of people in Medicare Advantage are there because of decisions made by their former employers or unions. And this is not choice, one of the things that's always said. The majority of states now offer MA to retirees. 13 states, including Connecticut, Medicare Advantage is the only option. But they're not getting more coverage for this than they would get in traditional Medicare. As we've heard, there are limited networks of doctors and healthcare facilities, usually only in their geographic areas. Prior authorizations and ongoing denials are denied at an astounding rate. And if people have the fortitude to appeal, which most don't, they are overturned if you stick with it at an astounding rate. Almost all healthcare providers and facilities, on the other hand, are available to people throughout the country in traditional Medicare. Why are we paying so much more for so much less and for such a lot of mishigash, for hassle and trouble when someone's sick and or injured? This costs the Medicare program and taxpayers more. It's bleeding the solvency of the program. My organization is committed to helping make the reforms that are necessary for traditional Medicare so that it can provide the promise that was guaranteed in 1965 to provide uniform, understandable care when people need it, where they need it. What needs to be done is that the program that serves all traditional Medicare programs at the very least needs an out-of-pocket cap so that if people need Medigap coverage to pay for that cost sharing that Representative Johnson spoke about, it would be capped at a certain amount. Right now that's available in Medicare Advantage, not in traditional Medicare. An out-of-pocket cap. We need Medigap reform, which is the insurance people have to buy to pay for the cost sharing, and limit the amount of what's necessary there. Connecticut's only one of 4 states where people with pre-existing conditions can get Medigap plans to cover all their conditions and can get it not just when they first enter Medicare. So we can, as others have said, urge people, look before you look. You can make a change now, beginning on October 15th and going through December 7th. But we need reform. We need to pay for what people need and stop paying insurance companies an astounding rate to deny what people need when they're sick and injured, which is what happens to all of us. Thank you very much.
So we're a bit over time, and I think some people have to leave. We will take questions. I also have some pamphlets back here that have step-by-step explanations on how to get out of Medicare Advantage into Medicare, particularly if you live in one of those 4 states New York, Connecticut, Vermont, and Maine. Are there any questions?
Yeah, so with the Medicare Advantage, are we getting the sense that the issue is inherently with the plan itself, or is it with the application of the plan by the insurance providers, or probably a bit of both?
So the question is it the plan itself, or is it the application?
Yeah, by providers.
It's the way the system is set up. The insurance companies are allowed to offer Medicare benefits. And as Susan said, the law requires they provide the same amount. They're required to provide at least the same amount. But there's no proper oversight. Different administrations, it's at federal level, have provided some oversight and then less oversight. The plans are, it's kind of the Wild West. They are able to say that they have a skilled home care benefit. And as Representative Johnson indicated, they're required to under the law. But then when you go and try and get home care for a loved one or yourself, you'll find that they say, well, they only have a nurse. They don't have home health aides. And there's no oversight to require that they do provide that. There's inadequate oversight of the brokers who shouldn't be making calls without being invited to do so, but do that. And then they also will get a higher commission for selling Medicare Advantage plans than for selling Medigap, which you need with traditional Medicare. So it's all of it. The statute is written broadly because it was expected that private Medicare plans would save money. In 1995, when these were set up, called something different, they were expected to be able to do the same thing as traditional Medicare at 95 cents on the dollar. Now it's costing us taxpayers in Medicare 22 cents more on the dollar for everyone enrolled in Medicare Advantage. It's a very, very powerful industry and lobbyists. And we need to make clear that this is not getting what we, the people, need in return. And there is hope because Fortune magazine last week had an article about this. Republican Dean Senator Grassley of Iowa has said this is unacceptable. So there's lots of need for oversight and rethinking this entire model.
Yes.
Yeah, can you explain a little bit about how we got here? I mean, these plans sound objectively terrible, but we're at a place where 56% of Connecticut Medicare beneficiaries are enrolled in them. You mentioned employers are enrolling people so they don't have choice. Like, what are the factors that made it so that a majority of Connecticut Medicare beneficiaries are enrolled in these plans?
Yes. So the question is,
How did we get here?
how did we get here?
And I was actually working with Judith Stein at the time that they changed there actually was health maintenance organization law in place back in the 70s. Nevertheless, it was so complicated, the insurance industry didn't want to go touch it. So some reforms were made under President Clinton in the mid-1990s to make it more available. But I have a little story about that. So we had in Eastern Connecticut, as you might know, we're not very densely populated. We had people signing up for that because they were going to get medication. At the time, Medicare didn't provide for medications. So people thought, oh, here's a chance to get the medication. When the insurance industry realized that they weren't getting the return that they wanted to have, they left Eastern Connecticut, and they announced that at a senior citizens place in Norwich. One of the beneficiaries at that time realized that he wasn't going to get any more medication through the HMO and had a heart attack right there during the announcement and died. Yeah, you were there?
I was there.
You were there?
I was the next person to speak.
Yeah.
Fooling with people's lives. I'm sorry, but I was at that meeting. It was, and so was Joe Courtney, our representative, And it was filled to the brim because, as you said, I think 14 plans were pulling out of the state. And what happened was, and this is part of what we're reading in the press now, seniors, and by the way, it's older adults and people with significant disabilities have Medicare. They are becoming almost their own worst enemies in that they're accepting, like this gentleman did, that he was going to lose his Medicare. We were there to try and explain to people, you have Medicare. Your particular Medicare Advantage plan may be, and in his case was, pulling out of his area, but he wasn't losing his health insurance. But, you know, there's a lot of emotion and stress involved with all this. And that was just such a compelling example of careful how you scare people and don't explain to people what's really possible. And that's part of how we got in Connecticut, where we worked hard with the legislature where you can get a Medicare plan so you can afford to go back to traditional Medicare. And that gentleman's wife would have been able to was going to get her Medicare. He unfortunately passed away. I'll never forget. That's what we're playing with people's lives. And it's not necessary. Medicare is there for them.
So to follow up, the Bush administration changed the Medicare plans and changed the name of the plans from the Medicare Part C HMO to Medicare Advantage. And they really increased the reimbursement rate, so the capitated payment system that they have under the HMOs for any HMO was increased to the point where we have heard over and over again since then that the amount that is paid under the Advantage plan far exceeds what is getting paid for in the regular Medicare fee-for-service plan. And that has been something that the insurance lobby has had a lot to do with on the federal level also. What's happened there is, for example, when President Biden proposed to add the dental, hearing, and vision to regular fee-for-service Medicare, the insurance lobby industry went bonkers about it and did not want to have that chance to make that advertisement that we're going to be hearing a million times if you're watching any television at all during the next few months, because the enrollment starts on the 15th of October. So that's that. So then the reimbursement rates went up. The private insurance industry started to gain, and that's kind of like what happened. And at the same time, one little warning too about some of this is that some of the Advantage plans do pay for Medicare Part D, some do not pay the premium. And so what happens is people trying to transition out of that are in a situation where they are going to have to pay a penalty if they try and leave the Advantage plans. And I don't know if you wanted to speak to that.
Well, I can't really speak to that. I will add to that, though, but there's one more question here.
Just a quick question. I appreciate all your comments. And I just want to say that as a retiree from the state of Connecticut, I do not have a choice between Medicare and Medicare Advantage. I was put in Medicare Advantage. I had zero choice. I am part of a group with Gloria of Connecticut State retirees who are trying to fight for the choice to be given back to us. So anything you can do to help us would be great. We are the Connecticut State employees for Medicare Choice. So thank you for everything you said. I really appreciate it.
Amen. Thank you.
Thank you. I actually wrote a little note here a little while ago to pass to Senator Anwar. We need a law that requires retirement plans to offer Medicare as an option. And that's way overdue. And then to add to the answer to the second question, healthcare should not be a for-profit industry. It's an industry, but it should not be for-profit. Car manufacturing is for-profit. There's nothing that says, well, you may need a car. In this society, most people do need a car. But you don't need a red 2021 Mustang, and you have to have that car. But in medicine, you may need to have a specific procedure to save your life. And so you have no choice. And why should profit be any consideration at all in that? When we have a profit-based healthcare system, which we do, we spend almost twice as much as the average of the other industrialized countries, but we have the lowest life expectancy, we have the highest maternal mortality rate, etc. And it's because Medicare, if they collect $100, they pay out $98, close to it, in healthcare. But Anthem and United Healthcare and so forth, they collect $100 and they try to keep as much of that money as they can because that's their profit. They have every incentive to keep that money, and they have minimal incentive to make sure that you get absolutely the best care. And the for-profit healthcare industry really, unfortunately, has gotten more and more powerful. And as they pass, they're going to be 55% this year nationally. And as they go higher and higher, they're just going to get more and more powerful. And if you look at Project 2025, the part about healthcare says Medicare Advantage will become the default choice for healthcare, the default choice. They want to completely eliminate Medicare, and we have to stop that.
Just back to that point.
We are working in coalescence with a bunch of organizations. See Sheldon Talbot's here, he's part of it, and a whole bunch of organizations throughout the country who represent people who rely on Social Security, who have disabilities, who have ALS, who have significant conditions. And our work was originally about Medicare for all. But more and more people became not just us Medicare geeks, but people who help take care of people who are ill or injured, recognized that Medicare Advantage was becoming Medicare, and that Medicare Advantage was not serving the people it was intended to provide care for. So one further warning is, do not let Medicare for all become healthcare for all. It's going to be a wider and wider scam to get the likes of some of us who spend our life trying to get coverage and health care to people who are providing it, to misunderstand that Medicare for all right now would mean, even if it was just the way it is now, almost 2/3 of all all people would then have Medicare Advantage. So we're trying to make that clear. Megan Bent joined me and others at the Capitol last year to try and make that clear and to counter the dozens and dozens and billions of dollars being spent by the insurance industry and the healthcare plan industry to have Medicare Advantage not have any cuts, get increases, and become Medicare for all. So careful what you wish for, be careful and listen carefully.
One more question?
Yes. So when did Medicare Advantage become the default for state employees? And what was, and do we know the reasoning behind that? I assume it was to save money, and it's turned out not to be doing that. And
Well, it can save the state money.
yes, okay,
It doesn't save the people who need healthcare money.
yes. And do we know statistically, I know the network coverage is only one small part of it, but do we have any sort of data to show, coverage in network with providers from regular Medicare to Medicare Advantage? Does that question make any sense? I'm sorry, I worded that poorly.
Say something quickly about that.
Yes.
Because one of the problems with privatization of any healthcare and health insurance is the data, as a general rule, is a trade secret. Right. So we have a real hard time getting the information. And one of the problems that we had back in the day when we had the Medicaid program, that was the oversight was through the private insurance industry. We had to sue twice to try and get the data. So whenever it's privatized, they have certain rights to the data.
Right.
And so that is another aspect of this, so you don't get the whole picture. I haven't seen, for full disclosure, I haven't seen the contracts between the Advantage plans and the federal government, but that would be a place to look to see where the data is and whether or not it is being shared in terms of how they're providing the coverage. But because it's a trade secret, as a general rule, whenever it goes private, it's going to be very, very hard for the government to get the data that it needs to make sure that it gauges how it does the coverage.
I can't promise you that they would have the data that you're looking for, but the KFF, Kaiser Family Foundation.
Great resource.
I've become a real junkie on information about these things. Kaiser Family Foundation has a daily email that comes out. And that's where I found information about the number of hospital systems that are pulling out of Medicare Advantage and the trend of providers to no longer take it either. So I would check them out.
Awesome, thank you.
The website is kff.org. And also, one other point, I agree entirely, and I see a lot of our colleagues who do, that KFF is really a source of wonderful information. Also, CMS, the Centers for Medicare and Medicaid Services, currently has the will, if not the way, to oversee this better. And they are working to enlarge the data that they will require from Medicare Advantage plans. And we have hopes that that will happen in 24, 25. Because there may be private, the plans say this is proprietary information, but it's all paid for by public dollars.
Right.
They're feeding it the public dollar trough. And they're the agents of the Medicare program. So I would argue that that's not private or proprietary information, but it takes the will of the people in power to say, we want to see who's being denied, for what services, and how often, and we can then compare it to traditional Medicare.
Awesome, thank you.
So CMS does have the will and not the way. Their budget for investigators has been slashed, and that just makes it easier. So my last word is there's one Medicare. Nationally, there are 3,964 Medicare Advantage plans to choose from. Why is that? Because they don't want you to be able to choose the best plan for yourself. And with that, I will give Senator Anwar the last word today, and thank him again for hosting, and thank everybody for being here.
Thank you so much. I just wanted to add a couple of thoughts. This is a symptom of a broader issue that we're dealing with. In this building and many other buildings like this, there's a conversation that we need efficiency, we need privatization. These are code words for taking the taxpayer money. And so this is what has happened in the past, and this is the manifestation of what has happened in the past, resulting in the taxpayer money being used and taken and put in the pockets of already very, very rich publicly traded companies. And this model is not sustainable. Whichever place that you start to hear these kind of conversations, start to ask a lot many questions. Thank you.